Good morning, everybody. Today's topic of discussion is rotator cuff injuries and associated pathologies. So, the rotator cuff injuries were first described in 1834 by Smith. This is one of the most common cause of shoulder pain. The incidence of rotator cuff injury it increases with age. It ranges from 5% to 40%. So, as we know, the rotator cuff is made up of four muscles. So these are the supraspinatus, infraspinatus, teres minor, and the subscapularis. So all of these arise from the scapula and they insert onto the tuberosities of the humerus. So here the supraspinatus, it arises above the spine of the scapula and inserts to the greater tubercle. So infraspinatus also inserts to the lesser tuberosity, and the teres minor and the subscapularis on the lesser tuberosity. The supraspinatus, infraspinatus, and teres minor insert to the greater tuberosity and the subscapularis to the lesser tuberosity. And between these two tuberosities is the tendon of the biceps. So we'll discuss about the function of the rotator cuff muscles later on. So the main function of the rotator cuff is dynamic stabilization of the glenohumeral joint. So normal function of the shoulder is a balance between mobility and stability. The most common etiology for a rotator cuff tear is the impingement. So other causes like trauma, aging process, it can lead to degenerative tears in the rotator cuff, ischemia of the tendon, lack of nutrition to the joint, and iatrogenic conditions. Iatrogenic in the sense when some surgeon inadvertently like damages the rotator cuff during a subacromial decompression. So there are different types of the acromion. So the most common type associated with the rotator cuff tears is the type 3 acromion. So type 3 acromion is a hooked acromion wherein the acromion is pointed anteriorly and forward. It forms a kind of a hook. This hook impinges into the rotator cuff muscles and eventually damages the cuff. So hook type of acromion is most commonly associated with the tears. So classification based on the duration, rotator cuff tear can be classified into acute or chronic tears. Based on the degree of tear, it can be a partial or full thickness tear. According to etiology, it can be a traumatic tear or degenerative tear. The degenerative tears are the ones associated with use of the shoulder joint, like age-related degenerative conditions. And based on the size, it can be classified into small, medium, large, and massive. The small is one which is less than 1 centimeter, and massive is more than 5 centimeters. So another classification is Hellman's classification. Based on the location of the tear, it can be a bursal tear, articular tear, or an interstitial tear. So bursal tear is just below the subacromial bursa. Articular tears are inside the shoulder joint. Based on the shape of the tear, also it is classified into different shapes. So the most common symptom of a rotator cuff tear is pain on the lateral aspect of shoulder. The pain can radiate to the deltoid. It can radiate to the anteriorly to the acromion. So most of the times, rotator cuff tear is associated with bicipital tendonitis, and there will be a stiffness of the shoulder joint. The patient cannot move the shoulder in all the directions. And also, one of the common symptom is the patient will report to you that he is not able to lie on the affected shoulder at night. Assessing the shoulder pain, the components of assessment include focused history taking, physical examination, and tests. So focused history taking, the most important thing is like the mode of injury. Since when is the pain started? Is it associated with injury? Most of the patients, younger patients, they report a history of injury associated with the tear. However, the elder patients, they say it is, I don't remember. Many of the patients say that they don't remember any history of injury. So the occurrence of pain will be spontaneous in most of the elderly patients. So in the history, we need to differentiate the shoulder pain with the pain arising from the cervical spine. All of this can result in referred pain to the shoulder. So cervical spine causes such as spondylolysis, arthritis and disc disease, cardiac causes, diaphragmatic irritation can also cause shoulder pain, and complex regional pain syndrome. In physical examination, we need to do the inspection, palpation, the range of movements, strength testing, and special test. In the inspection, we can see swelling of the joint, asymmetry of the shoulders, atrophy of the muscle. Posture of the shoulder will be drooping to the affected side, and there will be stiffness and guarding of the affected side. Scapular winging may be present sometimes, and atrophy of the supra and infraspinatus muscle will be seen if there is associated nerve entrapment. So palpation of all the bony prominences around the shoulder has to be done. So palpation of the AC joint, sometimes it is associated with degeneration of the acromioclavicular joint. So bicipital groove palpation, tenderness will be associated if there is a bicipital tendonitis, and also in cases of slap tear. A slap tear is one where the attachment of the biceps is torn. So the attachment of biceps at the supraglenoid tubercle. So if that is torn, it is called as the slap tear. That is superior labrum anteroposterior tear. So bicipital tendon groove, bicipital groove tenderness will be present in such cases. Next is the assessment of range of motion. So evaluation of range of motion. If the movement is limited by pain, weakness, or tightness, you have to do passive range of motion. Lack of full range of motion is both active and passive. Passive is associated with adhesive capsulitis. So one of the way of assessing the movement of shoulder, the internal and external rotation, is by a test called as Applis crash test, where the external rotation is tested by asking the patient to touch the upper part of the scapula behind the back, and internal rotation is tested by asking the patient to touch the lower part of the scapula behind the back. And there are some special tests in the shoulder. There are many tests, but a few simple tests for understanding. So one of them for impingement test is the Neer test. In this test, the scapula is stabilized with one hand, and with the other hand, the arm is internally rotated and flexed and abducted. So if there is impingement, the patient will experience sharp shooting pain at the shoulder. So test for supraspinatus. So one of the tests is also called as the empty can test or the Jobe's test. In this test, the patient is made to abduct the shoulder in the scapular plane. So the arm is internally rotated and ask the patient to abduct it in the scapular plane. And also it can be checked against the resistance to check for any weakness. So if there is weakness of the supraspinatus, the patient will not be able to do this test. Another sign is the drop arm sign. When there is a complete rupture of the rotator cuff, especially the supraspinatus, the patient will not be able to abduct the arm and sustain in that position. So this is an example of a drop arm sign, wherein the patient, after passive abduction, he is not able to sustain and he is not able to gradually bring the arm down. So there is a sudden drop in the arm. So this is called as a drop arm sign. So the function of infraspinatus is external rotation. So this is tested by checking the external rotation against resistance. So if there is weakness, it can be elicited by doing this test. The function of subscapularis is internal rotation. So this can be tested by two ways. One is asking the patient to press the belly, and also another test called as the Gerber's lift off test. So in this test, the patient is asked to lift off the arm above the back. So if he's not able to do the lifting off the back, then it is due to the weakness of the subscapularis. Now coming to the investigation, the most common and the first investigation is the X-ray. So careful look at the AP X-rays will reveal some sclerosis or lysis at the level of the greater tuberosity as well as some sclerosis at the acromion. So careful observation is very important in rotator cuff, chronic rotator cuff tears. So these signs are present only in chronic tears. So axillary view is done to evaluate the glenoid and the humeral head. So in supraspinatus outlet view, so we can see a type 3 acromion with a sharp hook-like projection. So this is seen in the supraspinatus outlet view. So this hook, it impinges into the rotator cuff. So the next cheap and easy test is ultrasound test. Ultrasound examination. So ultrasound will give a good definition of the rotator cuff. It also allows dynamic examination. This is one of the advantages of the ultrasound compared to MRI and X-ray, wherein we can evaluate a dynamic examination and also we can see if there is a dynamic impingement. So most of the time, if the if the ultrasound or the MRI, if it is done in a static position, in one particular position, will not be able to evaluate a dynamic impingement which can occur at 60 degree of abduction. So MRI is the best diagnostic aid. It defines the cuff damage. It also tells about the quality of the cuff. If there is any atrophy, exact shape, size, and location of the tear can be visualized using MRI. So these are a few images of the MRI wherein normal cuff is visible with the continuity in attachment to the greater tuberosity. In the full thickness tear, there is a breach in the continuity of the rotator cuff. So treatment depends upon the severity of symptoms, the age of the patient, activity level, and the patient requirements. So conservative management includes rest, activity modifications, NSAIDs. However, long-term NSAIDs are contraindicated. Physiotherapy, such as stretching and strengthening exercises, can help in partial tears, and injection therapy is suggested only in bursitis. So injection therapy, especially the steroids, should not be used in partial tears because it can lead to progression of the tear to a complete tear. Operative treatment is done only if the conservative treatment fails for at least 6 weeks. Operative treatment involves patient selection. The patient selection criteria was given by Samuelson in Binder. So patient should be physiologically younger than 60 years. So what we mean by physiologically younger is even a patient with 90 years, a rotator cuff repair can be done provided he is active and physiologically fit. Clinically or orthographically demonstrable rotator cuff tear, failure to improve with non-operative management is also an indication for at least 6 weeks. If the patient is involved with a constant overhead elevation and use of the shoulder, so operative treatment is indicated. Full passive range of motion should be present, and ability and willingness to cooperate is very important. The poor prognostic factors in rotator cuff repair are old age. Old age, again, it is the physiological old age, more than 60 years, and long history, no history of trauma. No history of trauma are the degenerative tears wherein there is no history of trauma and the muscles have damaged and torn because of the atrophy. Smokers have a poor prognosis. Multiple steroid injections can have a poor prognosis even on operative repair because of the degeneration and atrophy of the tear, atrophy of the muscles. Diffuse osteopenia, grade 3 or less external rotation, and upward migration of the humeral head. So these are the poor prognostic factors and should be explained to the patient before the surgery. So what are the surgeries in rotator cuff tear? So we can do an open repair or we can do an arthroscopic repair. The advantages of open repair are it is easy to do, no special equipment is required, direct visualization of the rotator cuff, and it takes less time to do an open repair. The disadvantages are it requires a detachment of deltoid. However, newer techniques, there is a mini open repair also where the deltoid need not be detached. And in cases of false positive MRI, this can lead to unnecessary open exploration. Significant intra-articular pathology like a slab tear will be missed in open repair because the region of the slab, the attachment of the biceps is not visible by open repair. Arthroscopic rotator cuff repair, the advantages are it has a lesser morbidity. It has the ability to identify other pathologies inside the shoulder joint. It is an outpatient procedure most of the times and allows to address small undetected tears. And patient acceptance is very high with the arthroscopic repair. The disadvantages are it is technically difficult and the cost of the implant in arthroscopic repair is high. It also increases the OR time and the learning curve is very long in arthroscopic repairs. So this is a demonstration of the arthroscopic repair wherein two portals are created into the shoulder joint. The rotator cuff is visualized. Anchors with sutures are placed onto the bone. The sutures are passed through the rotator cuff and the sutures are tied and the rotator cuff is approximated. So this is a technique called as the double row repair. Post-operative plan in arthroscopic treatment, you can start immediate active and passive range of motion. So however, active abduction should be restricted for 4 weeks. Active abduction should not be done. And later on, electrical stimulation and resisting exercise can be started after 4 months. Open repair, you have to proceed slowly and it requires 1 to 2 additional months for recovery. Complications, if the rotator cuff are not treated, it can lead to progression of the lesion. Even a partial tear can progress to a complete tear if it is not treated on time. It can lead to rotator cuff arthropathy. Long head of biceps can undergo rupture and it can lead to instability of the shoulder. Cuff tear arthropathy is a late sequelae of rotator cuff tear. So this leads to loss of the rotator cuff. As a result, the head is migrated up and then it starts eroding onto the acromion, leading to acetabularization of the acromion. So it forms a false cavity, articular side of the acromion. So this is called as acetabularization of the acromion. So cuff arthropathy has 4 stages. It is described in Hamada and Fukuda classification. So where the grade 1 is the initial rotator cuff arthropathy and with atrophy of the muscles. And the last stage is a stage 5 arthropathy where the head is completely damaged with acetabularization of the glenoid and acromion. Treatment of rotator cuff arthropathy involves shoulder arthrodesis. So earlier when there was no replacement for the shoulder, so they used to do arthrodesis of the shoulder. So the shoulder was fixed in a particular position. Then came the hemi replacement and finally the total shoulder replacement. So in total shoulder replacement, you replace the glenoid as well as the humeral head. The prerequisites for, so there are certain prerequisites for shoulder arthroplasty. The most important is the adequate power of the deltoid. So deltoid should have good power for the arthroplasty to be successful. This is a newer arthroplasty technique. It's called the reverse total arthroplasty, wherein the ball of the shoulder joint that is put onto the glenoid. So normally there is a head of the ball is present on the humeral head, and the the glenoid. So the cavity is reversed. So the ball is put on the glenoid, and the socket is on the humeral head. So this is called as the reverse total shoulder arthroplasty. Now, here I would like to present one interesting case which walked in my clinic. He's a 15-year-old male. He came a couple of months back to the clinic with severe right shoulder pain. This patient is a bodybuilder and he has no comorbidities. And he also had a rotator cuff tear 10 years back, which was done in US. So this is the initial X-ray. So on clinical examination, this patient had severe pain. He had all the tests positive. He had a test positive for the supraspinatus tear as well as the slap tear. So on X-ray, we can see a hooking of the acromion. So this is a classical type 3 acromion, which can better visualized in the outlet view. So there is a hooking of the acromion, and also this is the old implant which was used for fixation of the rotator cuff in the first surgery. On MRI, there is discontinuity of the supraspinatus, and this area is the area of the old implant. And also there was a detachment of the biceps tendon. So this is called as a slap tear, where the biceps tendon is attached to the superior glenoid labrum. So this is torn. On CT scan, we can see a classic hooking of the acromion here. So it's like a beak of a duck. So this sharp projection from the acromion, it digs into the supraspinatus and causes the tear of the supraspinatus. So in this case, this patient had almost all the pathologies of the shoulder. He had a subacromial impingement with a type 3 acromion. He had a slap tear. He had a rotator cuff tear. Also, this patient has had a slap tear with biceps tendonitis. So biceps tendon was also damaged. So in this case, we had to do a rotator cuff repair, a subacromial decompression. We had to do a slap repair, and also we had to do a biceps tenodesis. So normally after 50 years of age, we don't do a biceps tenodesis, but since this patient was a high demand individual, he wanted to maintain the shape of the biceps. So we did a biceps tenodesis in this case. So this is a video of the subacromial decompression where we use a high-speed burr to shape the undersurface of the acromion. The acromion is shaped and flattened. This is the patient after 1 week of the surgery. So his rotator cuff was repaired. So this bandage on the arm, the wound on the arm is for the biceps tenodesis, where the attachment of the biceps is removed from intra-articular side and it is fixed in the subpectoral region. So this patient had very good range of motion at 1 week itself because this patient had conditioned his muscles. So the muscles were in good shape. So he was able to achieve good motion at 1 week. Now this is at the end of 1 month. The patient is very happy and he is flexing his biceps. So there is no deformity on comparable to the left side. So the patient was very much satisfied with the surgery. Now, the conclusion here is the diagnosis is usually by good history and examination. Non-operative management is done initially. Avoid repeated steroid injections. Again and again, this is very important that repeated steroid injection should be avoided. And even if the steroid is given, it should be done under ultrasound guidance, and it should not be injected directly into the rotator cuff. So eventually, if the steroid is injected into the rotator cuff, it can lead to atrophy and damage of the rotator cuff over a period of time. Surgery is done in physiologically active individuals. So arthroscopy is a preferred choice now, like it helps in early mobilization and decrease morbidity. So treatment is according to the patient's needs. So thank you very much.